Hello, my name is Jeremy with Faith the Guardian Training Center, and today we're going to talk about chest trauma. We're going to continue on the things that we were talking about earlier, such as going on the anatomy. Now we're going to get into the pathophys of chest trauma. So you got two main mechanisms of injury. You have blunt trauma and penetrating trauma. Blunt trauma is going to be anything that doesn't penetrate the skin. Penetrating trauma is going to be anything that does penetrate the skin, such as gunshots, stabs, falling onto a piece of rebar, things like that. So you have two basic injury patterns, and that's going to be the closed chest injury and the open chest injury. So the closed chest injury, the skin over the injury is going to remain intact. The force was likely distributed over large areas, such as if you got hit by a baseball bat. And you can have injuries from, the visceral injuries, the internal, from the deceleration, the shearing forces. You can have compression and even a rupture of the tissues. The open chest injuries, that's when the chest wall has actually been opened and the force has likely been distributed over a smaller area, such as a stab or a gunshot, how it's very, very pinpoint. You can have fractures of the ribs that can occur from both bruises over the lungs and the heart. It's typically going to be blunt causes. You can have damage to the aorta, and as was mentioned before, whenever you break your first and second ribs, they do cause increased instances of damage to the aorta. And organs can be torn from their attachment to the chest cavity. So that's something that's really serious. You can also have blast injuries, and they can be both blunt or penetrating. You have the primary shock wave, which that's going to compress the organs, and then you can have the secondary phase. That's where thrown objects may penetrate the skin, such as from shrapnel. And all of these things can go into how the heart works by affecting the cardiac output, which again is calculated from stroke volume times heart rate. If you have anything that is going to diminish your stroke volume, it affects cardiac output. If you have anything that's going to diminish your heart rate, it is going to diminish your cardiac output. So, for example, some things that can influence your stroke output or your stroke volume is going to be your blood loss. You can have pressure changes. You can have vital organ damage where your heart's actually not pumping out as much as it was, or any combination of those. Bleeding into the thoracic cavity is going to lead to an increased incidence of hypovolemia and hypoxia. Your chest cavity is very, very large, and in an adult, it can easily hold 1.5 liters of fluid or 1,500 mLs, and that's going to be a massive pneumothorax. If this bleeding can do a couple of different things. So, for example, if you have bleeding outside of the pleural cavity, you're going to have increased intrapleural pressures. That means you're going to have decreased lung volume. You're going to have decreased oxygenation, and you can have that bleeding into the pericardial sac, into that space, and that's going to increase the pressure inside the pericardial sac, which is going to diminish the contractile force of the heart. Because it's going to have pressing on it, and Starling's law is not going to be able to have any much effect on there. And keep in mind, Starling's law is the rubber band effect. So, for example, the larger your heart gets, the more forceful the contraction. The more forceful the contraction, the more it's going to be able to relax out. Now, you can also have damage to the myocardial valve, and this can cause disruption of ventricular filling, and you can actually cause backflow into the atria. So, for example, if you have a mitral valve prolapse or tricuspid valve injuries, this is going to cause impeding function of the heart, because every time your heart contracts, your heart may actually be pushing blood backwards into the atria instead of pushing that blood out into the arteries like it's supposed to. Now, so something that can happen from blunt, such as so if you have somebody that gets punched in the chest or in a car crash, they can have a small tear in the myocardial sac. and so this can actually cause a rupture of the vessels of the heart itself. And you can have that's going to be that vascular disruption. A small tear or even a blockage, just like in a heart attack or a stroke, it can cause tissue ischemia. And the longer that tissue is ischemic, the higher the incidence is of it's going to become infarcted tissue or dead tissue. Ischemic tissue, you need to keep in mind, is just tissue that's been without oxygen. And if you were to give it oxygen, you allow those cells and those tissues to be able to oxygenate and properly participate in the perfusion process, you would likely have a return of function of those tissues. Now, ventilatory impairments can also be very fatal, such as if you have somebody that's being forced to breathe shallowly, whether it be due to something being crushed on their chest, or maybe even a pneumothorax or a hemothorax, it's going to reduce their minute volume. And if you reduce their minute volume, you reduce their alveolar minute volume, which is actually the amount of tissue or the amount of oxygen that makes it to the alveoli to actually be able to participate in gas exchange. Because you have to keep in mind that the dead space of your bronchi and your bronchioles, that's not participating in the gas exchange at all. And so that's definitely something that you got to keep in mind. And the way that you calculate your minute volume is going to be your tidal volume times the respiratory rate. So just like cardiac output is stroke volume times heart rate, minute volume is essentially how much air is being moved in and out. That's going to be your tidal volume, how much air you're bringing in one breath, times the respiratory rate. You can have air entering the pleural space of your chest cavity, and so what this means is that you have pneumothorax, or pneumo being air, thorax meaning thoracic cavity. So you have air in the thoracic cavity, and depending on where that air is building up, may also indicate what's going on. So for example, if you have a pneumothorax, you're not really going to have a whole lot of other associated factors from it, aside from the fact that you are going to have decreased ability to breathe because you're losing area of your lungs that's actually able to carry that oxygen. So as your lungs are getting compressed, it's going to cause you to breathe shallowly. Now, if you were to listen over your lung sounds, it wouldn't necessarily be diminished per se. It would be absent. So if you have absent lung sounds over an area, that's going to let you know that you may need to be doing a needle thoracostomy, where you take a 14-gauge angiocath and go through the pleural space, and we'll be sure to go over that at a later time. And you can actually have, as that pneumothorax develops, it can get to the point where it's going to become a tension pneumothorax. And so what that means is it's actually putting pressure onto the heart. And so it's going to have diminishing the cardiac activity. So with a tension pneumothorax, not only do you have decreased oxygenation capability because you've essentially lost an entire section of a lung due to being compressed by air, that air in the chest cavity is actually compressing on the heart. And so you're going to see a couple of different things from this. You're going to see JVD, which is actually going to be where your jugular veins are going to become distended. And you're going to be able to see that on your patient while they are laying at a 45-degree angle, which is the true way to establish JVD. Everybody naturally is going to have a little bit of jugular vein distension whenever they're laying flat. Something else that you will see with a tension pneumothorax is you will see tracheal deviation to the good side. So for example, if your trachea is midline right now, if it were to get shifted over here to the left-hand side, that left-hand side is going to be my good lung. Okay, so which would mean that if I were needing to do a needle decompression, I would need to perform that needle decompression on the right-hand side. And so that is, again, something that's going to diminish your oxygenation abilities, and it's also going to diminish your cardiac output, which diminishes your ability to be able to perfuse. This can also cause atelectasis, which is collapse of the alveoli. This is also an issue that you can have. So, for example, if you intubate somebody and you have a right main stem intubation, well, that means that you're ventilating the right lung, but you're not able to ventilate the left lung because the opening of your tube, the tip of your endotracheal tube, has been beyond the point of the carina, so the left lung is completely not able to participate in gas exchange at that point. So you have an entire lung's worth of dead space. And bruised lung tissue, so a pulmonary contusion, that can actually lead to significant hypoxemia or hypoxemia, so low oxygen in the blood, because those damaged tissues where you had the contusion, they may not actually be able to participate in gas exchange as well as the other tissues due to them being damaged. And you can also have tearing or rupture of the respiratory structures, and that's going to prevent any oxygen from reaching the alveoli. So, for example, if you have a tracheobronchial tear, that's where you have an actual tear from your trachea and your bronchi, and that's essentially cutting off anything past that point where that tear is. That's completely decimating that the ability of that segment of the tissues, the lung tissues, to be able to participate in gas exchange. So, for example, let's say that you have somebody who has they got shot in the left anterior chest. You are looking at them and you're doing your physical assessment. You notice that they have some tracheal deviation. You may notice that they have subcutaneous emphysema, which is where you actually have air building up underneath the skin, and that's going to be very indicative of tracheobronchial injury. And so what's going to happen is, as you continue to ventilate your patient, the more subcutaneous emphysema you're going to have. And the best way that I've been able to find to describe it is it kind of feels like a little bit like bubble wrap underneath the skin, because you have air that is under a tissue, which is going to be your skin. And that's not something that can be fixed through a needle decompressor or anything like that. That's something that is going to be fixed in the operating room. And something that you may need to do in those circumstances is look at where your tube placement is. Is it on the left side? Well, you may need to perform a right main stem intubation to prevent that subcutaneous emphysema from getting any worse, and prevent that potential pneumo from getting any worse. But you need to keep in mind where everything is, and listen to lung sounds, and be sure to treat your patients accordingly.